Today we will discuss very important topic, that is diuretics. What are diuretics? Diuretics are the group of drugs that increases our urine output. Okay. So what are diuretics? Diuretics are the drugs that increases the urine output. To understand the diuretic, we first understand how the nephron works. Nephron is basically structure and function unit of the kidney. Let's study the nephron and how it's working. So suppose this is our Bowman's capsule. This is the afferent arteriole, this is the glomerulus, and this is the efferent arteriole. This is the afferent arteriole, this is the efferent arteriole, and this is the glomerulus. Glomerulus is bringing the blood and it is being filtered in the Bowman's capsule. This is the Bowman's capsule and this is the proximal convoluted tubule. Okay, this is the proximal convoluted tubule. This is the descending limb of the loop of Henle. This is the hairpin turn. This is the ascending limb of the loop of Henle. This is the distal tubule, and this is the early distal tubule. This is the late distal tubule, and then we have the collecting duct. This is the collecting duct, and then we have the urine output. So basically this is the structure of the nephron: afferent arteriole, glomerulus, efferent arteriole. This is PCT. This is PCT, proximal convoluted tubule. This is the loop of Henle. This is the early distal tubule. This is the late distal tubule, and this is the collecting duct. Okay. So the basically diuretic group of drugs are working here. This is the first site, and here the drugs which are working are the carbonic anhydrase inhibitor. Okay, and this is the second site, and here the drugs which are working are called as the loop diuretics. And the drugs which are working in the early distal tubules are called as the thiazide diuretics. Okay, and the drugs which are working in the late distal tubule and the collecting duct are called as the potassium sparing diuretics. And there are two types. One group of drug block the epithelium sodium channel, and another group that block the aldosterone receptor. Okay, we have two types. One is the epithelium sodium channel blocker and aldosterone receptor blocker. This is the site of action of various diuretics. Okay, so this is the various sites. So anything, actually all the drugs which are working proximal to the potassium sparing diuretics, they causes hypokalemia. These group of drugs, carbonic anhydrase inhibitor, thiazide diuretics, loop diuretics, they cause hypokalemia. What they cause? They cause hypokalemia. Okay, another thing, the drug which is working in the proximal convoluted tubule and the drug which is working in the late distal tubule and the collecting duct, these drugs, what they cause metabolic acidosis. It make the patient acidotic. It also make the patient acidotic. Okay, this is another point you have to remember. Another thing you have to remember, the pump which is inhibited by the loop diuretics is sodium potassium 2 chloride symport. It is being inhibited by loop diuretics, sodium potassium 2 chloride symport, while the thiazide diuretics, they inhibit the sodium chloride symport. Okay, This thing you have to remember. So there are various side of diuretics. Another thing you have to remember, that loop diuretics here, it is effective even in low GFR. Even in low GFR it is effective. Okay, while thiazide group of diuretics, it is not effective in low GFR. So it is not safe to give thiazide diuretics in patients with renal failure. You can use the loop diuretics. Now we will study how the carbonic anhydrase inhibitors are working. Carbonic anhydrase inhibitors. What are the drugs for carbonic anhydrase inhibitor? We have the acetazolamide, dorzolamide, and brinzolamide. These are the three drugs which are carbonic anhydrase inhibitor. Okay, and how they are working, let's see. So when with the blood the filtrate is coming and it is being filtered, some solutes like sodium also filtered and some bicarbonates also filtered, even ammonia also filtered. Okay, but whatever they are filtered, they have to be reabsorbed by the PCT. But when we give drug like carbonic anhydrase inhibitors, the sodium bicarb can't be resorbed, as well as the sodium is not resorbed, bicarbonate is not resorbed, but this ammonia gets reabsorbed and it can cause hepatic encephalopathy in the patients who are on carbonic anhydrase inhibitors. Let's see how it is happening. So basically the sodium which is being reabsorbed, it is being reabsorbed here. How it is reabsorbed, let's see. When it is reabsorbed, it throws hydrogen ion into the lumen, and this hydrogen ion is produced because of the breakdown of the H2CO3, and this work is done by our carbonic anhydrase enzyme, which is being blocked by carbonic anhydrase inhibitor. So basically when this is broken down, carbonic acid into H positive and bicarbonate, so any drug which block this, it is not able to generate enough hydrogen ions to be put into the lumen. So when hydrogen ions can't go into the lumen, the sodium is not being reabsorbed and there will be natriuresis. Okay, another thing, this hydrogen has to combine with the bicarbonate to form the carbonic acid. Okay, and this is then converted into the carbon dioxide and water, which is being diffused into the lumen and converted into the bicarbonate. So when we giving the carbonic anhydrase inhibitors, hydrogen is not being regenerated and this bicarbonate remain as free, and it is also lost in the urine and produces the bicarbonate urea. Okay, there will be nitric acid, there will be bicarbonate urea. Also one important thing, when we give the carbonic anhydrase inhibitor, this H positive is not secreted, so ammonia can't be combined with the H positive to be excreted, so it is remain as such, and it is also diffuses and it goes into the circulation and produces what? Hepatic encephalopathy, because it reaches the brain and it is toxic for the brain. Okay, so this is few points about carbonic anhydrase inhibitor and what are the uses we can remember this game. It is used in acute congestive glaucoma because it decreases the aqueous formation, so it is used in glaucoma. It is also used in for alkalinizing the urine. So whenever the patient has acidic urine formation, for example in acidic poisoning, we can use it because it alkalizes the urine. Also in mountain sickness we use it. So in mountain sickness we use it. Why? Because the patient living in high altitude, they have increased respiratory rate, and because of which there is loss of CO2, and there will be alkalinization of the blood, and that is a bad stimulus that inhibits the respiration, which is bad. So when we give the drugs carbonic anhydrase inhibitor, they make the blood acidic blood, and which is a stimulant for respiration, so the respiration resumes. So in this way they are useful in mountain sickness. Another thing, they are also used in epilepsy because they increase the seizure threshold. Okay, these are the uses of acetazolamide. You can remember as GAME, game. They are used in glaucoma, they are used in for alkalizing the urine. They are also used in alkalizing the urine. They are also used in mountain sickness. They are also used in epilepsy. Okay, now we study various adverse drug ADR of or side effects of carbonic anhydrase inhibitor. So their structure resemble to the sulfonamide. So there is increased risk of hypersensitivity reaction. Further, they are also called as bone marrow suppression. They cause bone marrow suppression. Okay, so be careful in patients who are already anemic or having low platelet count or low blood counts. So be careful, or you can do the baseline CBC before prescribing these drugs, carbonic anhydrase inhibitors. Okay, then another drug effect is called as the hepatic coma. I already explained the mechanism. Okay, so these are the various uses and adverse effects of carbonic anhydrase inhibitors. Another thing, they also cause the hypokalemia. Okay, so what we are discussing diuretic, and in the diuretic we are discussing the carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors are acetazolamide, which is given orally for glaucoma, and another drugs are dorzolamide and brinzolamide, which is given topically for glaucoma. Okay, so these acetazolamide, dorzolamide and brinzolamide, when given to the patient, it comes into the glomerulus, and after coming into the glomerulus, it acting on the enzyme which is carbonic anhydrase, which is present in the lumen as well as in the proximal tubular cells, and it gets inhibited there. And because of the inhibition of this enzyme, the reactions don't proceed, and the hydrogen don't excreted into the lumen, and sodium can't be resolved. There is sodium loss, there is nitrogenesis, and further this hydrogen is not available to combine with the bicarbonate and or combine with the ammonia. So there will be the bicarbonate urea, and this ammonia, which is not being combining with the H positive, it is reabsorbed into the circulation, goes to the liver, and in liver, if the patient having liver diseases, the patient cannot metabolize the ammonia and goes into the brain and causes the hepatic encephalopathy or the hepatic coma. Then we study the uses of carbonic anhydrase inhibitor. We use them in you can remember at GAME, game. They are used in glaucoma. They are also used for alkalizing the urine. They are also used in mountain sickness. They are also used in epilepsy. Why they are used in glaucoma? Because they reduce the aqueous formation. Why they are used in acidic urine? Because they alkalize the urine by excreting the lots of bicarbonate. Also they are used in mountain sickness, mechanism I already explained, and also used in epilepsy because they increase the seizure threshold. And the structure is resembles the sulfonamide, so there is increased risk of hypersensitivity reaction. They also cause the bone marrow suppression, hepatic coma as well as hypokalemia. Now after studying the carbonic anhydrase inhibitor. Now we will take loop diuretics. Loop diuretics are working in the ascending limb of the loop of Henle. Ascending limb of the loop of Henle. Okay, they are working in the ascending limb of thick ascending limb of the loop of Henle. Okay, here the loop diuretics are working, and they are blocking this channel, which is sodium potassium 2 chloride symport. This is being blocked by the loop diuretics. Okay, and let's see what are various loop diuretics we have. We have this furosemide, which is also called as the Lasik, which we give in watts. We have the loop diuretics as furosemide. Then we have the bumetanide, and then we have the ethacrenic acid, and then we have the torsamide. Okay, among these the most potent is bumetanide. Bumetanide is most potent loop diuretic is bumetanide. Okay, and it is ethacrenic acid is most autotoxic. Okay, autotoxic, and torsamide have the long half-life. Okay, and furosemide has, in addition to the diuresis, it is also having the vasodilatory action on the blood vessels, so that's why it is using in to reduce the afterload in left ventricular failure. Okay, and also used in acute pulmonary edema. Okay, so what are loop diuretics? Loop diuretics, you can remember FPET. F for furosemide, bumetanide, ethacrenic acid, and torsamide. Among the loop diuretic, most potent is bumetanide. Okay, and the drug having the vasodilatory action is furosemide, and the drug which is autotoxic is ethacrenic acid, and the drug among the loop diuretic which is having the longest half-life is torsamide. Okay, they are working in the thick ascending limb of the loop of Henle by blocking the symport, which is sodium potassium 2 chloride symport. Okay, so basically this loop diuretics works well even in low GFR, so they maintain the GFR, and they can be used even in kidney failure. They can be safely given. Loop diuretics can be safely given in patients with low GFR. Okay, so what are the uses of loop diuretics? Side, uses, it is used in edema of all situations, edema of all kinds, all situations it can be used. Okay, so they can be used in edema due to the heart failure, they can be used in edema due to the liver failure, due to cardiac diseases, it can be used. Okay, so loop diuretics, it loses the calcium. This is important thing, loop loses calcium, so it causes the osteoporosis. While thiazide gains the calcium, loop loses the calcium. Okay, this is another thing you have to remember. And one more point, these loop diuretics are also called as the high ceiling diuretics. Why they are called as high ceiling diuretics? Because maximum water is being reabsorbed from this side. When this channel is blocked, most of the water does not get reabsorbed and there is a maximum diuresis, so these are called as the high ceiling diuretics. Okay, now we will see what are the side effects of loop diuretics. Basically, side effect you can remember by simple mnemonic GLUE. This is very good mnemonic to remember the side effects. It increases the glucose in the blood. It increases the lipid in the blood, and it also increases the uric acid in the blood. So it is contraindicated gout. It causes hyperuricemia. It is contraindicated diabetic because it causes hyperglycemia. And it decreases the electrolyte levels. Even calcium is also reduced. These are the side effects of loop diuretics. Similar side effects are also seen in thiazide diuretics, but in thiazide diuretics, the thiazide diuretics gains the calcium. But loop diuretics, I already told you, loop loses calcium. Very important point. Very important point. Okay, loop loses the calcium while thiazide gains the calcium. So these are the high ceiling diuretics I already explained. We already studied the drugs acting on the PCT, that is your carbonic anhydrase blockers. Drugs acting on the loop, that is the loop diuretics, blocking the sodium potassium 2 chloride symport. Now we will study the thiazide group of diuretics, which is working in the distal tubule, early distal tubule, and they are blocking this channel sodium chloride symport. So when the sodium chloride symport got blocked, sodium does not reabsorb as well as chloride, so there is a natriuresis and kaliuresis. Also chloride loss will be there, chloride loss. So thiazide diuretics acts by inhibiting this channel, this sodium chloride symporter. Okay, so the various drugs in this group we have, you can remember anything that is ending with thiazide, plus there are other drugs like chlorthalidone, like indapamide, and like metolazone. These are the thiazide group of drugs. Okay, so these are the thiazide drugs, and you know that chlorthalidone is the longest acting. It is the longest acting thiazide, longest acting. Okay, and the most potent thiazide you can remember as most potent thiazide diuretics are, we have the polythiazide and trichloromethazide. These are the most potent thiazide. Okay, and what are the uses of thiazide diuretics? You know that thiazide are the drugs of choice. They are the drug of choice for hypertension, first line drugs for hypertension. This point is very important, make a note of it. These are the drug of choice for hypertension, thiazide diuretics. Okay, further thiazide diuretics, they reduces the GFR, so they cannot be given in renal failure. Can't be given in renal failure or in condition where there is low GFR. So you cannot use the thiazide diuretics in renal failure. Okay, so they are, because of this effect, since thiazide diuretic reduces the GFR, so they are the drug of choice for diabetes insipidus. They can be given in diabetes insipidus. Okay, this thing you have to remember. So they can be used in hypertension, they can be used in diabetes insipidus. They can also be used in mild to moderate edema due to mild to moderate heart failure. Edema due to mild to moderate heart failure, they can be used. Heart failure, they can be used. Another thing is that the side effects is almost similar to the loop diuretics. You can remember as, already told you can remember as GLUE. It increases the glucose in the blood, so contraindicated, so not to be used in diabetic patient. It can increase the lipid, so hyperlipidemia can occur. It can cause hyperuricemia, so not to be used in gout patients. It decreases all the electrolytes, but it retains the calcium. So it is used for recurrent kidney stones. It can be used for the treatment of recurrent kidney stones. you can use the thiazide diuretics. Another thing, the mechanism of hyperuricemia in the diuretic, how it acts. Basically, this in the PCT, the thiazide are being excreted. In the PCT, thiazide are being excreted using the transporter. Similar transporter is used by the uric acid. So when you are giving the thiazide, it is being occupying this transporter. So uric acid cannot utilize this transporter to be excreted here. So this is blocked, and their circulation, in the circulation its level increases, and there will be hyperuricemia, and that precipitates the gout. Okay, this thing you have to remember. These are the various uses and side effects of thiazide diuretics. Again, I repeat, thiazide diuretics acts on the early distal tubule, and it blocks the sodium chloride symporter. Okay, so because of which there is natriuresis, caluresis, and also there will be loss of potassium, there will be hypokalemia. Okay, further, most of the electrolytes level decreases except calcium, which increases. So it is used for the treatment of recurrent kidney stones. So the various diuretics, we have the thiazide, anything that ending with thiazide or thiazide group of diuretics. Further, there are other drugs like chlorthalidone, indapamide, metolazone. Chlorthalidone is the longest acting thiazide diuretics. Okay, and the most potent thiazide diuretics are the polythiazide and trichloromethazide. Okay, the thiazide diuretics are the drug of choice in hypertensive patients. Okay, so it is also the drug of choice in diabetic insipidus. So be careful while prescribing thiazide diuretics in kidney failure, because it reduces the GFR and can precipitate the kidney failure. So be careful. Further, it can be used in edema due to mild to moderate heart failure. Okay, the side effect is similar to the loop diuretics, and you can memorize as glue. They are causing the hyperglycemia, hyperlipidemia, hyperuricemia, and decrease the electrolyte. Except the calcium, it retains the calcium and thus can be used for the recurrent kidney stone, for the treatment of recurrent kidney stones. Another very important thing I forgot to tell you, it not only decreases the electrolyte level, but it also causes the erectile dysfunction. It causes also the erectile dysfunction. Okay, now let's study various interactions with diuretics. Few interactions you have to remember. Okay, while giving the diuretics to the patient like loop diuretics and thiazide diuretics, you never give NSAIDs. Why? Because NSAIDs will inhibit the prostaglandins. Okay, and what these prostaglandins are doing, they are basically dilating the afferent arteriole and thus increasing the GFR. And because of the dilatation of these afferent arteriole, these loop diuretics as well as thiazide diuretics gain access into the tubular lumen and reaches its site of action. So if you are giving the NSAIDs and the diuretics like loop diuretic, thiazide diuretics, this prostaglandin get blocked and there will be vasoconstriction, and these drugs can't reach their site of action. So their actions will be attenuated. So there will be less effect of these drugs. So be careful while prescribing the drugs like Voviron, which is NSAID, and paracetamol. They may reduce the effect of the diuretics. Okay, another thing you have to remember that thiazide diuretics as well as loop diuretics, when given together, they decrease the electrolyte like potassium and like magnesium, and that precipitate our digitalis toxicity. Okay, digitalis toxicity. So that if patient is on digitalis, never give loop diuretics as well as thiazide diuretics in combination. Okay, this is another important point. Another thing is that whenever you are giving the diuretics, lithium absorption increases in the PCT, so there will be risk of toxicity. So be careful while using the diuretics. Lithium toxicity can occur. Okay, now we will study the potassium sparing diuretics. Potassium sparing diuretics are of two types. One, potassium that blocks the epithelium sodium channels, and another group of diuretics, potassium sparing diuretics, are the drugs that block the aldosterone receptors. Okay, so basically what they are doing, they are reabsorbing the sodium, and in place they are these are excreting the hydrogen and potassium. Okay, so when this sodium is not being reabsorbed, okay, it remain in the lumen, there is natriuresis, and because of which this hydrogen and potassium remain in the blood. So there will be increased risk of acidosis because of the hydrogen, and there is increased risk of hyperkalemia because of the potassium levels. So potassium share diuretics causes the hyperkalemia as well as the acidosis. So be careful in giving these drugs in the patients who are susceptible to acidosis and hyperkalemia. So what are the drugs that blocks the epithelium sodium channel? Let's study. Epithelium sodium channel blocker are amiloride. We have the amiloride, and we have the triamterene. Which is better? Amiloride is better. Why? Because triamterene has lots of side effects. Okay, we will study it later. And in the aldosterone receptor blocker, we have the spironolactone and aplinirone, and we have the canreninone. Anything that ending with one, that group of drugs are aldosterone receptor blocker. Okay, so let's study the amiloride and triamterene. Amiloride is better than triamterene. Why? Because triamterene has side effects like it causes the kidney stone formation, it causes the interstitial nephritis, it causes the kidney stone, it causes the nephritis. Okay, it also causes the photosensitive reactions. Okay, it causes the photosensitive reaction, and it also causes the megaloblastic anemia. Why? Because it is the folate antagonist. Okay, so triamterene has lots of side effects, while amiloride is more potent than triamterene. This is one thing you have to remember. Another thing is that it is the drug of choice for lithium induced diabetes insipidus. Why? Because amiloride block the epithelium sodium channel, and through this epithelium sodium channel lithium is reabsorbed into the circulation. So when it gets blocked, lithium toxicity can occur. So amiloride is the drug of choice for lithium induced diabetes insipidus. Okay, now about the spironolactone is usually we give it is in the patient who are having the cirrhotic edema. Patient having the liver failure and is having the edema, you can give the spironolactone. Further, it is an anti-androgen, so it is also being tried in the treatment of hirsutism. It is also tried in the treatment of hirsutism. I want to tell you one thing, that aldosterone receptor blockers like spironolactone, epinephrine, and canreninone, these are the only diuretics which are acting from the interstitial side. Rest all the diuretics acting from the luminal side, but it is the only diuretics that are acting from the interstitial side and blocking the aldosterone receptors. Okay, this is important point. Take it. We can make a note out of it. Okay. So it is used in cirrhotic edema, it is used in hirsutism, it is also used as an adjuvant. These potassium sparing diuretics are used as an adjunctive treatment to loop diuretics and thiazide diuretics to prevent the hypokalemia, because they are basically preserving the potassium. So when we are giving the thiazide and loop diuretic, there is a lot of potassium loss, so we have to combine them with this group of drugs. Okay, the spironolactone also very useful in conditions like heart failure. Okay, because it reduces the mortality in such conditions. Okay, this is important point. Okay, and what are the side effects of spironolactone? It causes the gynecomastia. These are the adverse reaction. It causes the gynecomastia, and it also causes the impotence. Okay, remember, make a note of this. And I want to tell here a mnemonic to remember the drugs that are causing the gynecomastia. Drugs causing gynecomastia. you can remember it by mnemonic DISCO, DISCO. There is digitalis. There is isoniazide. There is spironolactone. There is cimetidine or ketoconazole as well. Cimetidine or ketoconazole, and estrogens. These are the drugs that causing the gynecomastia. Remember as DISCO. Okay. Another very important thing, spironolactone is just like an loop diuretic. Spironolactone, because spironolactone loses calcium like loop diuretic loses calcium, while amiloride preserves, it gains calcium. Okay, that's good. Spironolactone loses calcium, amiloride gains calcium. This important point, interaction, you have to remember this. Okay. Another thing is that you should not combine potassium sparing diuretics with ACE inhibitors, because it can lead to the dangerous hyperkalemia. Okay, so I repeat, potassium sparing diuretics are of two types. There are one group that blocks the epithelium sodium channel and another group that blocks the aldosterone receptors. And these aldosterone receptor blocker are the only diuretic that are acting from the interstitial site. Okay, while rest all diuretic acts from the luminal site. Okay, by blocking the epithelium sodium channel and aldosterone receptor, they do not allow the sodium to resorb, and there is natriuresis, and because of which the hydrogen and potassium they exchange. So when this is not resolved, they retain in the circulation, so there will be acidosis and hyperkalemia. The drugs in the epithelium sodium channel blocker we told amiloride and trimetrine, and in the aldosterone receptor blocker we have the spironolactone, aplinterone and canrenone, anything that ending with 111, that are the aldosterone receptor blocker. Uses for the spironolactone we use in cirrhotic edema, hirsutism and heart failure. In the heart failure, it reduces the mortality. Okay, adverse effect, it causes gynecomastia and impotence. INEC blockers, amiloride most potent than trimetrine. Trimetrine has some side effects like kidney stone, nephritis, photosensitivitis, megaloblastic anemia. And amiloride most potent, and it is the drug for lithium-induced diabetes and insipidus. And the drugs that are causing the gynecomastia, I told you, you can remember DISCO, digitalis, isoniazide, spironolactone, cimetidine, or ketoconazole, and estrogens. Interactions, you don't combine potassium sparing diuretic with ACE inhibitors, dangerous hyperkalemia can occur. Okay. Now few points about osmotic diuretics. What are their site of action? They are basically acting at the loop of Henle and the PCT. This is the site of action for osmotic diuretics. The drugs in this group, we have the Mannitol, which is given IV. We have the glycerol. We have the isosorbide, and we have the urea. These are given through oral route. Okay, so Mannitol is given for increased intracerebral pressure. We use the Mannitol, but be careful, don't prescribe these diuretics if the patient is having active cerebral bleed. Don't give these drugs. Okay, so these drugs, Mannitol, given in the raised intracranial pressure, while these are given orally or topically. We can given this group of drugs for so these group of glycerol, isosorbide, they are given orally for the treatment of cerebral edema and cerebral edema and glaucoma. Okay, so these osmotic diuretics, it properties it should have, it should be osmotically inert. It should neither reabsorbed neither secreted. Okay, it should be osmotically effective and pharmacologically inert. It should neither be reabsorbed neither be secreted. Okay, it should be freely filtered at the glomerulus, freely filtered. These are the properties of an ideal osmotic diuretic. Okay, another thing, the side effect is it causes osmotic diarrhea. So when we are giving this drug, it is going freely into the circulation moves, and it drags the water with it, and which then enters the glomerulus and retain the fluid. Major side of action is the loop of Henle and all the water that is retained in this loop of Henle and excreted out as urine. This is how the osmotic diuretic acts.